Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm delighted to have with me today Dr Pipin Singh. Welcome, Pip.
Hi, Pat.
So Pip is a regular contributor of learning materials to the MIMS Learning website and is also an experienced speaker and chair at our live events. For example, Pip has chaired our 4-day digital event, MIMS Learning Live Digital, providing the perspective of the GP at the coalface, which is absolutely essential for delivering the right learning to our audience. He's got lots of experience delivering learning on a variety of topics, and today we're going to be talking about fit testing from the GP's point of view. Fit testing is vital in trying to pick up more cases of bowel cancer, and according to NHS England, the introduction of home testing kits has already led to more detection of cancer. However, the home screening kit is of course different to the use of fit testing by GPs and the nuances of that, so that's what we're going to be talking about today. So Pip, my first question is, what is the GP version of fit testing and what's it for? Is it only for cancer?
I think before I answer the question, I think it's worth just saying how widely recognised that individual symptoms are poor predictors of colorectal cancer. So if you take individual symptoms like diarrhoea or constipation or a change in bowel habit, we do recognise that they are poor predictors of bowel cancer. If you start to combine symptoms, that's when you start to obviously worry a little bit more about bowel cancer. But this is where fit testing has been incredibly helpful in primary care. So the aim of the fit test is to help risk stratify and determine the next best set of investigations and management for the patient that's sat in front of you. For those listeners that don't know, fit testing stands for faecal immunochemical testing. And in simple terms, it looks for microscopic blood in the faeces. It became a mandatory part of the GPs working up those that they suspect of colorectal cancer around the start of the pandemic, so around March, April 2020, although it was being used in the screening programme prior to that. It's basically based on a reaction to the hemoglobin breakdown products rather than whole blood, which is what fecal occult blood testing used to look for in the test that used to be used in screening beforehand. Fit testing has a very high sensitivity for picking up colorectal cancer and identifies those that are at high priority for full colonoscopy. Yes, in answer to your question, it is only for cancer, and it's in the symptomatic pathway. The cutoff is anything above 10. That would make us worried about someone possibly having colorectal cancer, but the cutoff is slightly different in the screening programme.
So how often would you use fit testing in your daily practice?
So that's a little bit tricky to answer because it will depend obviously on how many how many sessions each individual GP does. So it depends on your own individual clinical workload, I suppose. And I'd expect an 8-session GP, which I'm classing that as full-time, seeing patients only with no other commitments, to be requesting a fit test at least 4 to 5 times a week, I would say. And I'm basing this on the fact that a GP may feel the need to order this for a lot of vague symptoms that we see, such as non-specific abdominal pains, vague changes in bowel habit, borderline anemias which aren't necessarily fitting into a nice little box. And these are the sorts of things that are common weekly presentations for GPs.
Yeah. Okay. And so what would prompt you to use a fit test?
Okay, so there's obviously the guidelines that we follow in terms of symptoms. So NICE guidelines would be important to follow in terms of who should be offered a fit test. And NICE say we should be offering a fit test to those patients with an abdominal mass or with a change in bowel habit or with a new iron deficiency anemia. Mm-hmm. Any patients that are aged 40 and over with unexplained weight loss and abdominal pain, or aged under 50 with rectal bleeding and either of the following unexplained symptoms, so abdominal pain, weight loss, or aged 50 and over with any of the following unexplained symptoms, rectal bleeding, abdominal pain, weight loss, or age 60 and over with anemia even in the absence of iron deficiency. And it should be noted that fit should be offered even if the patient has had a previously negative fit through the bowel cancer screening programme for the reasons that I've just mentioned before about the cutoff, the ranges being slightly different. People with a sort of rectal mass or unexplained anal mass or unexplained anal ulceration do not need to be offered a fit before referral is considered. But you'd have to check with your local policies on that one because I do know some areas do differ in their approaches to that. For example, where I work in North Tyneside, fit is a very much a mandatory part of the referral in terms of the form, and you have to have a very, very good reason as to why you shouldn't have attached the fit results attached to the referral forms that you're sending. But NICE are very clear that if you do have a rectal mass, unexplained anal mass, or unexplained anal ulceration, you don't need to necessarily do a fit test. Okay.
Right. Great. So is it possible for you as a GP to remember all that list that you just told me about with the different age ranges and what to look out for in each age of patient? Or do you just do you have to stuck up on the wall? How do you manage that?
Yeah, well, there is a little bit of that, yes, no doubt. And I think each GP will have their own system and their own ways of doing things. And that's part of what we learn during training. And obviously we can't memorize absolutely everything that we need to know for every condition. That's near on impossible. And part of a GP's role is knowing where to look for the right resources. And every PCM will have their own pathways and policies that they follow. So a good starting point is always NICE in terms of what the national guidelines are. CKS is a fantastic resource as well, which often summarizes what NICE are saying. There's obviously the MIMS stuff that we have, which often form good resources for GPs, which you can just dip in and out of if you want to look something up. And the local pathway forms, so the local 2-week wait forms, will often have the criteria that patients need to meet to be able to be referred to that particular speciality. So it's worth looking at the referral forms. And some GPs may wish to do that with the patient in the room, so that they're directing them to the right place and that they're not delaying anything and so forth. And there's no harm in doing that. Patients appreciate if you may not know something or you need to look it up and you need to explain that to the patient that you need to look at it. Patients are often very appreciative of that because it shows that you're taking them seriously and you want to help them as best as you possibly can. And you joked about having things up on your wall, but I have loads of things stuck up on my wall like this. I know plenty of my colleagues do as well. So whether that be on your virtual wall, so your desktop, or whether that be an actual bit of paper physically stuck to a wall, that's another way of doing it as well.
Absolutely a good way of keeping things at front of mind. So my next question was around thresholds for 2-week wait, or as it's now known, the faster diagnosis standard referral, and how community testing and your type of fit testing fit together, which was something you touched on briefly a minute ago, but perhaps you could go into that a bit more detail.
The upshot with this is that for 2-week wait, if someone's got symptoms, the cutoff is 10 micrograms per gram of hemoglobin. And if you're screening, i.e. they've not got symptoms, the cutoff is 120 micrograms per gram of hemoglobin. And that's what the lab will be looking for in terms of level of microscopic blood seen in the feces. And the difference is basically because in terms of screening, what you really don't want to be doing is overloading the system. So the national screening program, the bowel cancer screening program, when they were looking at this, basically set the level of 120, and it was basically based on health economics and to avoid overloading endoscopy services. Because if the cutoff was lower for screening, what they found was you would end up overloading services, which meant that people who have got symptoms, you just wouldn't be able to see them in a timely manner. So hence the difference between the thresholds for the 2-week wait and for the screening program.
But if somebody's come to see you with symptoms, then obviously there's more concern there as a baseline, isn't there? So, yeah.
Yes, absolutely. And if someone's seeing you with symptoms, as I mentioned earlier, even if they've had a negative fit test through the bowel cancer screening program, you should still be offering that patient a fit test due to the threshold, the cutoffs and the thresholds being slightly different. And obviously, if someone's got symptoms, that means that they may well have a pathology there that needs to be investigated. So that does become more of a concern. So it's quite different to a screening program.
So would someone with a positive fit test immediately meet the requirements for a 2-week wait referral, or other criteria that need to be met as well?
So there'll be a reason the test's been ordered in the first place. So if a GP is ordering a fit test, there's often a patient come to see them with some form of symptom. Now, that might be one of the symptoms that I've touched on from NICE guidelines. It might be a set of very vague symptoms. And as with GPs, we often see very vague symptoms, as you know. So a lot of this will go back to the pre-test probability of colorectal cancer and clinical judgment. What is the likelihood that you felt that the patient sat in front of you has colorectal cancer based on your history you've taken and your examination findings? Now, this is something as GPs we're doing day in, day out, every day with every patient that we see, working out even if it's subconsciously, what's the pre-test probability of that patient having a particular pathology?
Yeah.
So if you've ordered a fit test, there's something in your mind that could mean that this patient's got colorectal cancer. Now, you might not have that high on your list of differentials, it might be a little bit lower down. So if the test has been ordered in the correct context, i.e. on the basis of symptoms suggestive of colorectal cancer, and it is positive, then yes, they are likely to meet the threshold for referral. However, there might be some caveats to that, so if this patient's got particularly significant comorbidity, or if it's not been ordered in a particularly appropriate context. So it all goes back to that pre-test probability of why did you do that test in the first place, which applies to absolutely any test that we order as GPs.
Great, thank you. So does a negative fit test always rule out colorectal cancer?
So it's very clear in all the research and the trials and all the resources that we read around FIT is that at the end of the day, it does remain a test. And we know all that tests do carry although that tests are good and can be very good, particularly as we know the FIT's got a very high sensitivity, they do carry their own limitations. And we do know that a small proportion of colorectal cancers will have a negative FIT test. But it's just important to remember that the sensitivity remains high, so in excess of 90%. So what I mean by that is if the test is negative, there's an incredibly high chance that this patient will not have colorectal cancer, which is what I mean by a high sensitivity. A patient's symptoms always outweigh the test results. So if a patient's symptoms are persistent despite a negative FIT, then continue to remain curious about that patient and have low thresholds for onward referral. And safety netting, which is the cornerstone of our day-to-day work, is incredibly important. Think about what information do you tell your patient in terms to what to look for. Share that information with the patient. Although this test is negative, you would be still concerned about ongoing symptoms. So yes, it's reassuring to have a negative FIT test. If there's ongoing symptoms, it is important that they are reviewed and set appropriate timeframes for review with that patient. So that might include a proactive review if you've got, say, more vulnerable patients, say someone with a learning disability or cognitive impairment or so forth, or if the patient may not have a vulnerability and you feel like they can take responsibility for their own health, then put the onus back on the patient to contact you in a particular time frame with the symptoms to look out for that you will have discussed with them in your safety net. And this is absolutely critical, continuity. And we all know continuity makes a big difference. Seeing the same doctor makes a difference. Knowing the doctor, knowing the patient knowing the doctor. And this is, I appreciate, becoming increasingly difficult with the current landscape of primary care. But if you've got that continuity, you can put that continuity in place, then that will make a big difference if you see that patient again, purely because you know what you've done. You're the one who's assessed them initially, you've examined them, you know what you found, and you can decide with them what the next best steps might need to be.
Absolutely. And as you say, that's the principle that the symptoms outweigh the tests. And I guess that's something that GPs do have in their mind all the time in their clinical work. Testing's one thing, but the wider picture is what's more important.
And that's what we do best, Pat, as GPs. We're holistic. And one thing that maybe doesn't happen as much as it used to in secondary care is holism. The way secondary care is fragmented a lot into very niche specialties, subspecialties and so forth. We're often the people now who pick up when someone's had a negative test at the hospital and what we might need to do next. We're often the ones who know the wider implications of testing with a particular person because we know them from having known them from years gone by. We know their families, what makes them tick or what doesn't make them tick. And we're in a good position to often have a good conversation with them about what the next best steps might need to be, factoring in their life really, because at the end of the day, these things are not just disease specific, they're specific to the person sat in front of you.
So what do you do if a patient has a positive FIT but returned with negative colonoscopy?
If they've got a positive FIT, the risk about a negative colonoscopy, the risk, as ever these days, the risk is often transferred back to primary care, as most 2-week wait pathways, once, say, for example, that particular colonoscopy is done, they will end the pathway, the 2-week wait pathway, and it's very unlikely that they'll have a further outpatient consultation with a physician to discuss that result. it'll often be that they'll get a report or we'll get a report with some findings on. And it's not uncommon for patients to come back to find out what was found at colonoscopy if it's not explained to them at the time of colonoscopy. So more often than not, I would say patients do come back to us, and then it's up to us to consider further investigations if we feel that it's appropriate. So it would go back to basics, really, the history, the examination, and again, this is where continuity is absolutely critical. There are conditions that can cause false positive fit tests, so that's something to bear in mind. Things like infective gastroenteritis causing a colitis, things like an inflammatory bowel disease picture, which can do it, polyps and so forth, so that you can get false positive fit tests, but you may well have something on a colonoscopy which isn't a cancer, which may account for why the fit test is positive. You might not, and that might be where, as I say, you go back to basics. What was your history? What was your examination? Can you leave it there with an appropriate safety net, or do you maybe need to think about some advice and guidance from gastroenterology, or possibly even an onward referral routine to look into why they've got a positive fit but a negative colonoscopy if they've still got symptoms? Now, if they've not got symptoms, the symptoms have resolved, the fit test is positive, nothing's been found on colonoscopy, the chance of a significant condition causing that positive fit test is very, very low. So you can probably be reassured, and you can reassure your patients accordingly. It's also worth bearing in mind that colonoscopies can miss cancers as well. So that's something to factor in.
Yeah, more kind of nuance. So how do you manage your referrals whilst waiting for the fit test result?
So there are circumstances, and I think I've touched on that a little bit earlier on in terms of anorectal mass, ulceration, and so forth, where you wouldn't need to offer a fit test. However, most 288s do mandate the fit test for all referrals, even in the presence of a mass as well. So that's just something to bear in mind. So it is important to have a clear in-house protocol for how to hold your lower GI referrals until the fit test is returned. So it will often take a few days for the patients to receive the kit, because we have to order it as GPs. The kit will get sent to the patient's house via the mail service, and the patient obviously has to do the test, return it, and then it goes to the lab to be analysed, and we get the report. Often the turnaround time, if the patient is quite prompt at returning it, can still be around 4 to 5 days. So there is a period of time where you will have the lower GI referral, but still have to hang on to it before you can send it, because you haven't got the fit test result. So it is important for your surgeries to have in-house protocols for how to hold your lower GI referrals until the fit test is returned. And that can be something you can work out with your secretaries if you haven't got something in place. It could even be possible med student project, F2, or GP registrar project.
I was going to just ask, what's your impression of the usefulness and benefits of fit testing in terms of outcomes that you've seen? Do you think it's affected the outcomes for your patients?
Yeah, so I think on a population level, it's obviously improved screening due to the accuracy of the test. And then on an individual level, Pat, it's definitely reduced the need for invasive investigation. There's no doubt about that. And it's incredibly helpful for deciding which patients can be managed in primary care versus secondary. Plus, it's helpful to us in deciding on the urgency of referral if the latter remains indicated, i.e. referral. There's challenges, though. I'm not going to sit here and say it's all rosy, and I think most GPs will appreciate the challenges. And the challenges that we're often left carrying what feels like a lot of risk, particularly in some of the situations that we've discussed already. So the positive fit test, but the negative colonoscopy, the risk that a colonoscopy might miss a cancer. And historically, pre-fit test, some of the more grey areas would have been managed with a plan from lower GI. But now with the fit, we are left holding a lot of that risk, such as the vague lower GI symptoms and the negative fit, the persistent symptoms and the negative fit, the positive fit and the negative endoscopy, holding the referrals whilst you're waiting for the fit test from the patients, because, we don't quite know when that fit test is going to come back. As I said, with the best intention, you're looking at a few days. If someone's decided to then go on holiday, or they've got a chaotic lifestyle, you throw in mental health problems, drugs, alcohol, vulnerabilities, sometimes it takes a lot of prompting to get patients to return their tests. And yes, okay, I appreciate the onus is on the patient to give us the test, and if we've explained to them why they need to do it, we should be expecting patients to do that, and we shouldn't be shouldering all of that responsibility. But there's no doubt that as GPs, we do feel a bit of that responsibility.
That's understandable. I can see that you're keen to avoid an adverse outcome, so you need to know that the person's done their test.
Absolutely. And there's still unknowns as well, Pat, I would say. Those with a lot of the trials around fit testing was done in patients who's above the age of 40 with symptoms. So we're still unsure about the validity of fit in those with symptoms less than 40. We're still not sure about when a repeat test might be helpful.
Uh-huh.
And also, I think there's some work, there is work being done at the moment about the appropriateness of fit testing in certain groups. So those that are unable to do tests, say blind patients, for example, those as touched on a little bit before, with learning disabilities, with cognitive impairment. So there are still unknowns that are yet to be answered with regards to fit testing.
Yeah, no, that's really interesting. I was actually going to ask you about younger patients, because there seems to be some kind of a bit of coverage in the news about bowel cancer affecting younger patients. So you just said, I think, that there's not so much evidence about use of fit in people under 40. Is that right?
Yes, that's correct. And again, it goes back to that history, that examination, that overall assessment, that pre-test probability. Okay, so what is the likelihood that the patient sat in front of you after history and examination has got colorectal cancer? How acute is it? How long have they had the symptoms for? Are there any other systemic symptoms at all? It's important to inquire about family history of colorectal cancer. There are loads of things as GPs that we will assess to evaluate the pre-test probability of a particular condition. And I would still do a fit test in those particular patients, even though when you click the boxes to order the fit test, it's kind of almost adds an extra barrier if the patient's below 40. But I would still recommend that this is carried out if you are worried about the patient sat in front of you who you think may have bowel cancer, but just because they're under 40, I would not do a fit test because of that particular reason. So yes, still do it, although the validity of the test is questionable. And if it's positive, you're still going to be referring that patient in or having a discussion with your local GI team.
Yeah. Okay, thank you. And finally, could you talk to me about a patient for whom fit testing was or was not useful?
Yeah, so I thought I'd pull this case together. It's just someone I've seen not too long ago. It was a 65-year-old diabetic gentleman. He presented with an 8-week change of bowel habit to me with more diarrhea. His past medical history included a TIA. He also suffers from irritable bowel syndrome historically, but he felt like his particular symptoms were different to his IBS. His father's brother had colorectal cancer, so he was a little bit worried about that, but there was no recent history of travel and he had no other red flag symptoms. He'd had a little bit of PR bleeding, which had been fresh on his paper, but he's had that for years, and he was told that he had some hemorrhoids in his 30s, so that hadn't worsened. So he wasn't particularly concerned about that. It was more about the change in bowel habit. He was taking naproxen, PRN for arthritic pain, lansoprazole as some stomach protection for his naproxen, and clopidogrel for his previous TIA, and metformin, dapagliflozin, atorvastatin, and also some paracetamol, again for arthritis. His medications hadn't recently been changed at all, nor had he started anything new in the last 12 weeks. That's a little bit of background to his story.
Yeah.
I performed a GI exam, including a digital rectal examination, which was normal, and I arranged some blood work. So usual bloods, full blood count, TSH, U's, celiac screen, and I also ordered some stool cultures as well, just to exclude an infection, a fecal calprotectin, and also a fit test. I discussed stopping his metformin temporarily, knowing that metformin is one of the often the common culprit for diarrhea, regardless of when it started, and very, very specifically arranged to review him with myself. So I proactively booked him in. I said, see you again with the results, and we can discuss the next steps depending on what your symptoms are doing at the time. So on review, his symptoms are 30% improved. So I reviewed him a couple of weeks later and his tests were normal. I re-weighed him and thankfully his weight was stable. So for me, that was just quite an interesting case because historically it may have felt appropriate to refer him pre-fit test, 8-week change in bowel habit, a little bit of a family history of bowel cancer, and someone over 60. But he had no red flags and he had a negative, and because he had a negative fit test, I felt much more confident to manage the risk and uncertainty and trial him off his metformin. And also, I should have mentioned, I did trial him off his lansoprazole as well, just to see if that made a bit of a difference, because we know that lansoprazole can cause diarrhea, and I replaced that with famotidine as an alternative to a PPI. So I restarted him back on metformin. Sorry, before I should say that, I should say I arranged when I saw him at his review, his symptoms had totally resolved. And his weight had remained stable.
Oh, that's good.
So that was just an example of someone where, as I said earlier, you may well have referred before you had a fit test, but because I had a negative fit test, and knowing that sensitivity of that fit test is in excess of 99% in the absence of other red flag symptoms and with a normal examination, as I said earlier, I was happy to manage him in primary care. Whereas 5 years ago, I may well have just knee-jerk referred him on to secondary care. Although knowing that a metformin and a PPI can cause diarrhea, I may have been less likely to hold on to that risk, just given the fact we didn't have a test like the FIT test, which we know is pretty accurate or pretty sensitive.
Yeah.
So in this particular person, I restarted some modified release metformin and up-titrated it just to obviously get back on top of his diabetes. And I added that to his repeat prescription. I put the onus back on him to let me know if his diarrhea worsened again. And I got a message actually to say, via my receptionist, he'd rang in to say that he was doing quite well on his new metformin and he'd had no further diarrhea. So I was happy to put that diarrhea down to his medication, whether that had been his metformin or the lansoprazole or a combination of the metformin and the PPI. So in essence, you could say in this particular scenario, the negative fit test avoided him having to have a colonoscopy, which comes with its own risks.
Great. You know, the NHS saved resources there by a referral not needing to be made. But also, hopefully, that was reasonably empowering for you as GP, that you felt you had more information to go on and could be more confident in your management.
That's right, absolutely. And yes, okay, it required maybe a couple of extra appointments to review. So there's always some downsides to things, isn't there? In primary care, we're faced with there are challenges in primary care, as we all know, and we are short of appointments and a lot of GPs' waiting lists will be long. And this is an example of where historically, yes, I would have referred him to lower GI and not needed to use those 2 follow-up appointments, perhaps. However, in this scenario, I needed to use the 2 follow-up appointments. But the flip side is that I wasn't subjecting the patient to an endoscopy at the end of it.
What would be the take-home points from our discussion today, Pip?
Obviously, I've talked a little bit about fit testing and its uses and some of the scenarios that you might encounter on a day-to-day basis. I would say my take-homes, Pat, are to remember the sensitivity of your fit test is high, as I've talked about a couple of times, in excess of 99%. Just a reminder, good little mnemonic I learned at medical school: spin and snout. A specific test rules it in, a sensitive test rules it out. So a highly sensitive test like FIT test rules out a particular condition. So the high sensitivity is good. It's still needed in patients, which I haven't really touched on actually, but it's still needed in patients with rectal bleeding, as it is helpful for secondary care to decide on what investigations are needed. Because a lot of people think, well, why do I need to do this in patients who've got rectal bleeding? They're obviously bleeding. Why do I need to look for microscopic blood? But actually, secondary care need it, as I say, to decide what investigations might be useful. And that might be a sigmoidoscopy versus a colonoscopy.
Right.
Symptoms will be on your local 2-week wait referrals. So don't be afraid to review this with your patients in the room if you need to remind yourself to ensure to get them to the right test. Remember, back to basics: good history, examination, review any previous test done. Again, maybe something I've not touched on so far, but if they've had a colonoscopy within the last 2 to 3 years, think again, do they really need to be subjected to another one? So if they are FIT positive, it might be that some other form of approach is needed. So have a look back in the records. Records have become increasingly complicated over the years, where we have access to so much data now. We get patients having tests done in all sorts of different ways through private providers. We get information from out of hours, 111, different types of teleservices that patients now access. So have a look. What have they had done with regards to GI investigations in the last few years if they are presenting to you? Have they been seen before? It's always something I teach my registrars. Have a look back. Have they seen someone about this same symptom before and had some tests? And if so, what was the outcome? Women need a CA125. So just remember that ovarian cancer can mimic some of these lower GI cancers. So if a female is presenting with some lower GI symptoms, keep that diagnostic net cast wide. Think, do I need to do a CA125? A lot of 2-week forms for lower GI will mandate that you do a CA125 in women.
Oh, that's good to hear. Yeah.
DRE, if you don't put, and again, another medical school thing for me, if you don't put your finger in it, you put your foot in it. Remember to do that digital rectal examination. It's really, really important, and something I always remind my trainees about. Think about how your safety net failed fit returns. So if you do get a patient who's not submitted their fit, what safety net do you have in place for that? So do you have an alert from the lab? Because in where I work, the lab actually send us a notification saying the patient's not submitted their fit test.
Oh, do they? Oh, that's interesting.
They do, and I'm not sure, Pat, if that applies to everywhere. So if it doesn't, think about how you manage your non-return fit tests. If you are in a fortunate position where the lab lets you know, great. And think about protocol for holding lower GI referrals pending the patient returning the fit test. What are you going to do with them to ensure that when the fit test does come back, you can then put the lot together and send it on accordingly. And the last thing from me, Pat, is continuity. Absolutely critical. We're talking about cancer a lot this year with MIMS, and one huge thing that we know works well is continuity.
Yeah. So an absolutely essential part of the picture.
Yes.
Well, thank you so much for all that added value with the takeaways. Really practical points there for GPs, and so valuable. Thank you very much. Thanks for being on the podcast again, and we'll definitely have you back next time.
No, thank you. Thank you for having me.
For our listeners, don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. This episode was produced by Till Owen. Don't miss next week's episode of the Clinical Update podcast. We'll see you then.